what's the best way to treat mental health? It's a constantly evolving topic as more research comes out year after year. Today, medication and therapy are often prescribed as treatments for mental illness, but that wasn't always the case. Back in the 1930s, many people with conditions like depression, OCD, and schizophrenia spent the majority of their time in hospitals or insane asylums. At the time, doctors experimented with different methods to find a cure. Treatments included sedatives, induced comas, and using electric currents that doctors said would shock patients out of their illnesses. We've since moved past many of these questionable practices, but one procedure continues to live in infamy: the lobotomy. It rose to fame in the early 1900s and showed promising results, but Dr. Jason Sheehan, a professor of neurosurgery at the University of Virginia, says that it wasn't the cure people believed it to be.
Oftentimes they were considering patients as having a successful outcome if they were less agitated and less anxious. The endpoints that were achieved were not ones where they would reintegrate into society as a perfectly normal neurobehaviorally patient. They were simply less anxious and less agitated in most instances, but by no means were they perfectly without behavioral or cognitive issues.
But was that for the benefit of the patient, or rather just making them less troublesome to society? Even with procedures that were considered successful, many patients had serious symptoms like bowel and bladder dysfunction, eye damage, and issues with their circadian rhythm.
What might be deemed success in terms of improvement in agitation and anxiety could also have had some of these other symptoms associated with it. Certainly the goals of creating a lasting remission of their underlying behavioral disorder was always there. Objective measures for doing that were less refined than they are now. And, for instance, for obsessive compulsive disorder, we have different validated tools to measure OCD in patients, and those have been consistently applied in major studies. And in the era of lobotomies, there was inconsistency in terms of the clinical endpoints for patients. In general, to say that someone improved may be a reflection of certain parts of improvement in their behavioral disorder, but certain parts of worsening in other aspects of their behavioral disorder or their overall neurocognitive function.
Despite this, the lobotomy offered a way to keep some patients calm and quiet by disconnecting part of their frontal lobe. After a couple of tests using animals, the first iteration of the procedure was created by a Portuguese neurologist who injected pure alcohol into the prefrontal cortex. It then evolved to use a needle-like tool to cut through white matter in the brain. He won the 1949 Nobel Prize for his contribution to psychology. Even though some surgeries worked, some made behaviors worse, and some did nothing at all. This wide range of outcomes could have been because neurosurgeons didn't really know the specific functions of each part of the brain like we do today.
An MRI, much less a CT scan, wasn't even available when they were doing these early lobotomies, so that really they were looking at the anatomic structures and saying, let's disconnect this, let's disconnect that.
Regardless, the practice quickly spread due to the lack of treatment options. In 1936, American neurologists Walter J. Freeman II and James W. Watts tweaked the procedure and coined the term lobotomy. They introduced a new method which used a hook to cut at the brain. And while neurosurgeons in the U.S. pushed back against the procedure, Freeman promoted the surgery so much that it became known to the public as a miracle cure. However, the early success has since been outshined in the eyes of history by the very public failures.
There were some historical and very promising successes from lobotomies, but then there were equally a number of patients, most notably one of the Kennedy sisters, who had a very unfortunate outcome and was largely hidden from her family by all accounts for an extended period of time because of an unsuccessful outcome from a lobotomy for what was a combination of perhaps depression and epilepsy associated with underlying neurological condition. Her speech was impacted, her ability to engage with family was impacted, and so that's an unpromising spectrum of lobotomies.
Rose Marie Kennedy, the sister of President John F. Kennedy, suffered from violent mood swings as a young adult. Freeman and Watts performed a lobotomy to calm her down, and while it ended her erratic temperament, The surgery had devastating repercussions. She spent the rest of her life in an institution and passed away in 2005. Despite its unreliability, the procedure continued to be a recommended form of treatment. Freeman performed or supervised over 3,500 lobotomies, even though he was not cleared to perform surgeries. But by the 1960s, antidepressants and other medications took over. The lobotomy has since been banned in countries like Japan and Germany, but it is still legal in America. Today, lobotomies tend to have an incredibly negative reputation since we can see the long-term effects and risks they carry.
The work by neurologist Freeman and then by accompanying neurosurgeon Watts that was done in the US really was deemed much more primitive and ultimately has had a stigma associated with neurosurgical procedures for complex psychiatric problems since that era. It's really been some of their work has tainted the field and has negative connotations.
Though not as common as medications, brain surgery is still a treatment option for mental illness. The difference is that now we have the knowledge and technology to make sure these procedures are successful for the patient. Sheehan's excited about a few rising treatment options, such as deep brain stimulation, or DBS. Electrical signals are sent into different areas of the brain to block symptoms of mental illness. Other options include using non-invasive gamma radiation and ultrasounds to calm down overactive areas.
Those are very different approaches, gamma knife surgery and focus ultrasound, from the things we just talked about with lobotomies, where we were going in and using almost a very primitive knife, if you will, to disconnect parts of the brain. So I think it shows how much we've improved and how much more sophisticated the approaches are. I'm optimistic that there'll be further advances in the field.
So while lobotomies are now recognized as dangerous and mostly unsuccessful, researchers are taking the findings of those surgeries and using that information to create new treatment methods.
Fortunately, I can say that the things that we've done in the past like that have caused us to learn and to be much more thoughtful about how we consider the brain and how we manage patients with behavioral disorders. And I do think that those patients who are undergoing procedures and who are undergoing clinical trials now are doing so for brain operations associated with behavioral disorders with a much more thoughtful and sophisticated sets of approaches and with lots of safeguards in place.
You can find more information about Dr. Jason Sheehan and all of our guests on our website, radiohealthjournal.org. For more behind the scenes, follow Radio Health Journal on Facebook, Instagram, and X. Our writer-producer this week is Annabelle Rivera. Our lead producer is Kristen Farah. Our production manager is Jason Dickey. I'm Greg Johnson.